Well, hello, everyone. Thank you for joining us today. I am super excited to be talking about this subject. We only have 1 hour to go over the surprisingly fascinating subject of pharmacological effects on the EEG. In this video, we're going to learn how these medications actually work. We will break down drug classifications, but the most important takeaway, I think, from this, we'll be looking at individual medications and discussing their unique effect on the patient and the EEG. So throughout this video, I suggest taking notes, in particular on maybe the back of note cards, and periodically go through each one so you can stay sharp on this topic, on this topic, because there is a lot of info we will be going over. So let's go ahead and get started. And I guess this is a good time to introduce myself. My name is Gil, and I'm a registered tech for over 20 years in the field and other modalities. I'm a former instructor of neurodiagnostics. I'm the co-founder and chief operating officer at Arium EEG, which is a remote EEG monitoring company. And I'm also the regional director of Apex Diagnostics, which is a neuropathy pain clinic with over 15 clinical sites around the U.S. So as you can imagine, I've dedicated my life to this industry, and I'm absolutely thrilled to speak about it whenever I can. So the goal of this presentation is for all of us to have a deeper understanding of how pharmaceuticals work and treat epilepsy. I think as we study for our boards, or at least while I was studying for my boards, I just memorized certain things about epilepsy treatment without, truly understanding what or how they actually work. So that's the goal for today. And I'm confident that you'll have a deeper understanding of these drugs when we complete this lecture, and in turn make you a better educated, more informed technologist. Also, if you are registered, it's giving you CEUs for free, so you can't beat that. But that's the goal for the presentation. Now, I'm a firm believer that the best way to learn something is to first understand its origin. When you unravel origins, you have a better understanding of how things work and how they became integrated into our lives. So that's how we're going to kick this lecture off, is starting off with the history of pharmaceuticals. So in the Middle Ages, apothecaries and pharmacies offered traditional remedies based on centuries of folk knowledge. However, in the 17th century, a wave of scientific thought and understanding absolutely swept the world. And it wasn't until after the Industrial Revolution in the 18th century that we fully began to modernize the pharmaceutical world. And in the 19th century, you saw mass production of goods combined with new scientific thought really propelled the drug industry to what it is today. So in 1827, a German business owner by the name of Heinrich Emanuel Merck, you might recognize his last name, perhaps became the earliest adopter of modern-day pharma. He was the heir of his father's company, Angel Pharmacy, where he manufactured and sold alkaloids. And fast forward to 1857, when an obstetrician to Queen Victoria by the name of Sir Charles Lockett serendipitously observed potassium bromide arresting epileptic seizures in 14 out of 15 subjects he was currently studying. Side note, potassium bromide is rarely used in humans today due to its damaging effect on the skin and central nervous system. However, it's actually the primary medication to treat seizures in canines. So that's a little interesting fact. So over time, researchers and pharmaceutical developers built a robust list of anti-epileptic drugs to treat a wide variety of epilepsies. So now that we know the history of pharmaceuticals, let's take a deeper dive into the medications that actually target epilepsy. So anti-seizure, anticonvulsant, anti-epileptic, AEDs, and ASMs, these are these are all really terms that we commonly use that roughly is referring to the same thing. So seizure medication. Yes, there's some nuance there, but for the sake of a general understanding, let's understand that their purpose is to treat epilepsy. We will be using the term ASM as it's the most accurate and up-to-date nomenclature that generally encompasses the goal of treating epilepsy. So anti-seizure, anti-seizure medications are unique in the sense that they do not cure epilepsy. Unlike, say, for example, taking a course of antibiotics for an infection, ASMs actually are preventative medications taken every day in order to control the frequency or even eliminate seizures while the person is actively taking the medication. Now, there are certain considerations to factor in when evaluating the effects of ASMs, whether it be efficacy, side effects, or EEG effects. And an obvious one is the quantity of medication. At therapeutic levels, most anti-epileptic medications have little or no effect on the EEG signal. However, medications exceeding toxic levels tend to demonstrate very clear effects. And along with the quantity of medication, the method of distribution and rate of metabolism can all affect the individual patient's response to these medications. And lastly, unique genetic and or epigenetic patient characteristics. For example, if you're looking at the effect of barbiturates on an individual who has chronic alcohol dependency, they may have a different response to barbiturates than does someone who has, let's say, never experienced alcohol. So ASMs are generally categorized into two main groups. You have the broad spectrum and narrow spectrum. So broad spectrum drugs are medications used to treat a wide variety of seizures, while narrow spectrum drugs are drugs that are prescribed for a specific kind of seizure, say, for example, focal seizures. Now let's take a look at this chart list of medications that fall into these two categories. So we have broad spectrum on the left and narrow spectrum on the right. In today's lecture, we'll go over each drug's purpose, effects on the patient, including side effects, and effects on the EEG. Now, when studying the pharmacological effects on a patient, it's worthwhile to consider that medication effects, generally speaking, are quite different from person to person. And why is this important? Well, to say that every person you see in a clinical setting will demonstrate these medication effects is, it's just plain wrong. And if you assume that these effects are hard and fast rules across the entire EEG patient population, you may misinterpret what the EEG is actually trying to tell you. However, on the flip side, it's important to know if any of these medications a client is taking is actually creating an effect on the EEG that would skew the expected EEG outcome. So in other words, always consider what medications an EEG patient is on. It may or may not have an effect on the outcome depending on the person. All right, so now let's first tackle broad spectrum drugs. Again, we'll go over each one. We'll learn the uses, the mechanism of action, or in other words, how it works in the body, the side effects, and last but not least, the EEG effects. Okay, clonazepam. Clonazepam is also referred to by its brand name, Klonopin. Clonazepam is helpful in conditions such as absence, myoclonic, atonic, and Lennox-Gastaut related seizures. Again, I would be either writing this down or taking screenshots so you can come back and reference these later. So let's take a look at how clonazepam reacts with the body in order to help with the previously mentioned conditions. So this is called mechanism of action. Again, it's another way of saying this is how the drug works in the body. Okay, so this is how we're going to do this. I have some screenshots taken from a video that we'll watch here in a second from the YouTube channel Drugs in Motion, and it's a great visualization of what's actually happening in the brain on a cellular level. So I'm going to first break down the video using screenshots. We'll get familiar with all the components, and then we'll watch the video together to see it in full action. I think it'll help really solidify what's going on a molecular level. Now, I'm only going to do this once just so you can get familiar with the components, and then we'll kick it into gear anytime we watch another one. Also, clonazepam is a benzodiazepine, and the mechanism of action for clonazepam is going to be the same across all benzos. So keep that in mind. So right now, we're looking at a neuronal synapse. That's just the space in between two neurons. And this right here is gamma aminobutyric acid, or GABA for short. So GABA is the primary inhibitory neurotransmitter, which means it decreases the neuron's action potential. And an action potential is simply the electrical impulses that sends signals throughout the nervous system. So if you're taking notes, you might write down GABA. That's GABA, and write down that you might write down that it's an important component to the process of stopping electrical activity. So moving on to the GABA receptor, you can think of GABA receptors as little doors that let neurochemicals in when open and keeps them out when shut, and that'll be important here in just a little bit. So when GABA binds to the receptors, it opens them up to let the chemical chloride enter. Okay, so GABA comes in, it attaches to these receptors, it opens them up, and then as you can see, these little blue molecules of chloride go through the GABA receptor, and that's what GABA does. So again, the little molecules you see here is chloride. And so what's chloride's role in all this? You're probably asking. Well, I'm glad you asked. And chloride is a negatively charged ion that stops electrical signals from passing through. Okay, so anytime chloride is going through, there will be no electrical activity. So as you can see here, chloride is flowing through the GABA receptor since it's open, and that makes the action potential just sit back and wait for its turn, like a good little sweet, polite impulse. It's just waiting for its turn. And all right, now as you can see, when the receptor closes up again, now those receptors open. Remember, those receptors open and they close, when they're closed, electrical activity can come through, can travel past. So that allows the electrical impulses to travel across the synapse into the receiving neuron, like we just said. And okay, so that was a description of an unmedicated neuron. Okay, so now let's talk about clonazepam and how clonazepam actually works on the neuron. So clonazepam is represented here as little white orbs bound to the receptor. You see the red arrow pointing to it. Now, when benzos bind to the GABA receptor, they increase the frequency that the receptor is open. And what does that do? That allows the chloride in more frequently. And what does chloride do? It stops electrical activity. So just a steady flow of chloride going here. And that is what controls the seizures. So, all right, so you've seen the components. Hopefully you have a general idea of what's going on here. So let's play the video in full action so we can get an even better understanding of the mechanics involved, okay? So let's see if this works. All right, so side effects. The literature on clonazepam is consistent, and most report drowsiness in about 26% of clients, mood changes in about 8%, and memory impairment in about 2%. Serious but uncommon side effects may include jaundice, hallucinations, and extreme allergic reactions. So clonazepam is a benzodiazepine, or benzo for short, like we said earlier, and perhaps you will notice similarities of other benzos in regards to the effects on the EEG. Some of you might know what I'm alluding to already, but almost every benzodiazepine medication will have similar results. So the first characteristic you may notice on a patient taking clonazepam may be the appearance of this beta rhythm that you see here, with the black arrows pointing. This is a 15-second fragment of EEG recorded in a 12-year-old boy in non-REM 2 sleep, and it shows excessive medium to high beta activity maximal bianteriorly, indicated by, again, the two black arrows there. So back in my day, we called this beta buzz, with the nomenclature changing what feels like daily. However, I'm not exactly sure if that's what they still call it, if they still call it by that name. But you know, it'll help you remember this effect. We called it the benzo beta buzz, so maybe that'll help you as well. All right, so the very first one is down. Let's move on to levetiracetam, also known as Keppra. Now, Keppra is one of the leading medications to treat epilepsy. Keppra is a relatively new drug, being first approved in the United States in 1999. So to compare that to a drug such as phenytoin, for example, Keppra came along almost 100 years later. So that's pretty significant. But Keppra is either used as sole therapy to control seizures, or is commonly used in a therapy cocktail, if you will. And the combination of Keppra with other meds can help control certain seizure types. Again, Keppra is in the broad spectrum category, so it's going to be helpful for a wide variety of seizures, such as partial, myoclonic, or tonic-clonic seizures. Now, funny enough, I'm going to get a little help from myself. I did a quick 2-minute video on Keppra, as a matter of fact, and I'm going to show you a little snippet of that, and it will explain the mechanism of action. So here we go.
Now let's get to the nerdy stuff. What you're seeing now is a typical unmedicated neuron, and that green ball moving down the neuron is a vesicle full of neurotransmitters. And the red thread-like protein surrounding it is called SV2. Now that vesicle needs SV2 to help it release the neurotransmitters once it gets to the end. After binding to the receptors are then opened up and the electrical signal is now able to pass through. All right, remember, that was a normal neuron vesicle without Keppra. Now let's take a look at that same vesicle in a patient who has taken Keppra. These are the molecules in Keppra binding to SV2 and stopping it from releasing those neurotransmitters from the vesicle. And now that there are no transmitters on the receptors, the electrical signal is stopped and therefore seizures reduced. Now this is about the time where we go over the EEG effects. However, most studies show that Keppra doesn't really affect the EEG in therapeutic doses.
All right, so there you have it. So as I said in the video, levetiracetam doesn't really affect the EEG in therapeutic doses. However, there are studies that suggest that Keppra can produce faster frequencies similar to benzos if therapeutic levels have been exceeded. So the literature on Keppra is fairly consistent, and most report drowsiness in about 15% of clients. Headaches came out to about 14%, followed closely by infection at 13%, and 9% reported complaints of dizziness. This poor fellow right there. All right. So moving on to lamotrigine or Lamictal. Lamictal is an ASM first approved for the USA in 1994. So again, this is a fairly new medication. And according to a study published in the National Library of Medicine, this broad-spectrum drug is considered a first-line treatment for primary generalized tonic-clonic seizures, for example, both simple and complex partial seizures, and focal onset tonic-clonic seizures as well as Lennox-Gastaut syndrome. The mechanism of action for lamotrigine is not entirely understood. Some studies do indicate that it's a sodium channel inhibitor. There's evidence that lamotrigine actually binds to the sodium channels, thus stabilizing electrical transfer from one neuron to the next, and that's how it's controlling seizures. Okay, so let's take another look at a mechanism of action video to help explain. Now, again, we'll go back. So that's we're right back at the neuronal synapse. Now, what we're looking at here in yellow is sodium, and then this is a sodium channel. Now, sodium is a positive ion, and unlike chloride, which is a negatively charged ion, sodium actually transmit electrical signals. So sodium and electrical action potentials actually get along. Now, here comes lamotrigine binding to the sodium channel and blocking sodium from getting through. With less of the positively charged ion entering, the electrical signal is stopped. Remember, if sodium's coming through, so is electrical impulses. If sodium is not getting through, electrical signals are stopped. And that's how lamotrigine is believed to control seizures. All right, so let's take a look at how this works in action. Okay, so despite individual variants in side effects of Lamictal, clinical trial data reveals that certain side effects tend to occur more frequently than others. You have vision changes, changes in coordination, skin rash, nausea, dizziness, and headaches are among the most commonly reported symptoms. The results of these clinical trials have shown that approximately 10% of users will discontinue lamotrigine due to unwanted side effects. It's pretty significant. So Lamictal has an effect on the EEG. It's been shown to decrease interictal spikes in photoproximal responses. And what we're looking at here is an event of a photoproximal response, just to illustrate what Lamictal reduces. So not a typical example in this lecture, but I think it's worth noting that that's what it stops or it helps. All right. Lorazepam. Lorazepam is a short-term treatment for all seizures, commonly referred to as Ativan. Lorazepam is used to control status epilepticus and generalized tonic-clonic seizures. So what's the mechanism of action? Just like its benzodiazepine relative, clonazepam, lorazepam binds to GABA receptors and increases the flow of chloride, therefore stopping electrical signals. As I'd mentioned, all benzos, a lot of benzos work very similarly, whether it be the mechanism of action or the effects on the EEG. So common side effects include drowsiness, dizziness, fatigue, and confusion. Serious side effects include allergic reactions, suicidal thoughts, and tremors. Well, just like I said in the last slide, you might begin to see similarities when it comes to these benzos. You saw it in the MOA, and now you're going to see it in the EEG effects too. So just like clonazepam, the effects of lorazepam has on the EEG consists of a loss of background rhythm, decreased voltage, and frontal beta. The frontal beta is commonly known, again, as beta buzz. So to better understand the seemingly universal characteristic of benzos on the EEG, let's take a look at this figure from Clark et al. In 2001. Here we have three traces of EEG where you have A is a normal EEG with posterior alpha and frontal desynchronized EEG. B shows synchronous beta activity in the frontal region. This is rhythmic beta activity, but it does not show a spindling rhythm yet. C shows clear beta spindles frontally. You can actually start to see the rhythmic beta with a center frequency, and it clearly stands out from the background activity. Okay, so next we have rufinamide. Now, rufinamide was approved in the United States in 2008 to be an adjunctive medication or an add-on seizure medication. This ASM is very helpful when combined with other medications to treat Lennox-Gastaut syndrome or Lennox-Gastaut-related seizures. It's useful in absence. It's useful in myoclonic and atonic seizure types. The MOA of rufinamide is almost completely unknown. There are some studies that suggest it is a sodium channel blocker as well. The literature on this is still minimal, so take that with a grain of salt. Now, side effects for rufinamide are headaches, dizziness, fatigue, nausea, and some tremors. Headaches were reported in 27% of clients. Dizziness was 19% of reported cases, and fatigue at 16%, nausea at 12%. So that's 27 for headaches, 19 for dizziness, 16 for fatigue, and 12 for nausea. So for rufinamide, there is no evidence of an effect on the EEG. I guess this is a good time to say that I'm actually still going to go over some medications that do not have an EEG effect for the simple fact, EEG effect for the simple fact that it's just as important to know if a medication does not have an effect on the EEG. Say, for example, you were presented with an EEG recording that was demonstrating an unexpected pattern and you knew the patient was taking rufinamide. If you were inclined to think that the pattern originated from rufinamide use, then you could immediately rule it out. When you inevitably remembered this highly educational talk, then you could subsequently move on and consider other factors. Okay, so for the sake of time, we're going to start speeding this up here just a little so we can get as much as we can. All right, topiramate, brand name Topamax, is the fourth broad spectrum ASM we're going to cover today. Topiramate is useful for controlling focal seizures with or without secondary generalization. Topiramate works on both. So furthermore, topiramate is often administered to treat all other seizure types as well. All right, now getting into the mechanism of action. Topiramate is special in a sense that it works on the body in two different ways. So we've gone over how benzos are GABA receptor enhancers, keeping them open for chloride to come through. We've also gone over sodium channel blockers such as rufinamide that we just went over, and how they block sodium channels, therefore reducing electrical activity from passing through. Well, what if I told you that topiramate does both? That's right. Topiramate is a GABA enhancer and a sodium inhibitor. It's all in one. So the most talented ASM when it comes to mechanism of action. All right, so cool. Let's go over its side effects. So the most common side effects for topiramate are thinking and memory issues. Secondly, weight loss is a very common side effect. As a matter of fact, some clients are taking topiramate for the sole purpose of losing weight. The data suggests that anywhere from 6 to 17% of individuals report weight loss in both adolescents and adults. Okay, when looking at a patient on topiramate and you see an unexpected output, you don't have to worry about topiramate being the cause because topiramate is like rufinamide and levetiracetam, and it does not, I repeat, it does not have an effect on the EEG. Okay, valproic acid, aka Depakote, aka Depakine, aka valproate, aka Depakon, is a broad spectrum medication that assists in the therapy of focal, absence, generalized tonic-clonic, and myoclonic seizures. And valproic acid's MOA is complex but very interesting. In fact, let's take a look at another video I have already made. Why do twice the work, right? So I'm going to put this video. I think it will help explain it a little better than just me talking about it now. So here we go.
Mechanism of action. The way a drug interacts with our body to stop seizures or regulate mood is called the mechanism of action. And valproic acid's mechanism of action is still unclear. However, most researchers agree that this is most likely a GABA enhancer. Let me explain. In our last video on Topamax, we went over how a neurotransmitter called GABA opens up receptors on the neuron and allows chloride to pass through those receptors. When chloride passes through those receptors, it stops the electrical activity. Well, unfortunately for GABA, there's an enzyme called GABAT. That's GABA with a T if you couldn't tell. And GABAT is kind of a bully to GABA. Now this is what GABAT actually looks like. And GABAT breaks down GABA every time it comes into contact with it. And with less GABA, the receptors stay closed and chloride isn't allowed to flow through. With chloride unable to flow through, that allows electrical activity to pass through. Okay, we're almost done. When valproate is taken, it binds to those little bully enzymes and blocks them from picking on GABA. That allows GABA to keep the receptors open and allows chloride to pass through more frequently, therefore reducing electrical signals. And that's how valproic acid helps reduce seizures and manage bipolar disorders.
Now, there are several effects of valproic acid on the patient. Some less serious are weight gain. This is it's less serious as far as it health wise. It's certainly not great for specific individuals, and we'll get into that. This is a concern for clients since research shows that about 50% of patients on valproic acid reported some increase in weight, tremors, hair loss, GI issues, and decreased blood count are other side effects. Aside from the weight gain at 50%, the other effects are actually less than 5. There are some serious side effects to valproic acid. I remember being a young tech in a neurologist record review session at the hospital that I was working. At that time, a younger physician was just getting completely reprimanded by the chief of neurology because he had prescribed valproic acid to a 17-year-old girl as her first attempt at therapy. Now, if you know anything about valproic acid side effects, you know that the chief of neurology was absolutely correct. And why? Well, let's say this patient became pregnant on Depakote. 1 in 10 children exposed to prenatal valproate develop malformations such as neuronal tube defects, cardiac malformations, and urinary tract anomalies. So in cases where the mother has used more than 1,000 to 1,500 milligrams daily, more than 1 in 4 will be affected by that. That's 25%, obviously, but that's incredible. The term fetal valproate spectrum disorder, or FVSD, has recently been introduced to describe the composite clinical picture of malformations, the cognitive impairments, the neuropsychiatric conditions, and dysmorphic features that can be seen in children who have been exposed to valproate. So not good, as you can imagine. The neurologist was right on point there. So the default therapy of valproic acid for a 17-year-old female in her reproductive stage is just not a good idea. So it's EEG effects. Here is another one with no significant alteration of EEG. So pretty easy to understand. Okay, everyone. Well, we're halfway through. Now, this might be a good time to pause, take a little break, grab a coffee, whatever you need to do. I'm going to take a break as well, and I'll be right back. I actually have a special surprise for you all when I come back. So, yeah, we'll talk about that here in a little bit.
Hey, Gil, you there? Come on, man. You said we were going to talk about narrow-spectrum drugs right now. All right. Well, I see all of you wonderful people here, and I've got another meeting starting soon. So let's go ahead and review this right now. Let's talk about narrow-spectrum drugs. So broad-spectrum anti-seizure medications can be used for a wider variety of seizure types and are a good initial choice when the classification of seizure types is unclear. Unlike broad-spectrum anti-seizure medications, narrow-spectrum drugs usually work more effectively for a specific type of seizure, such as focal seizures. So, for example, oxcarbazepine is used to treat focal seizures and can even make other seizure types like myoclonic and absence seizures worse. Well, there's an interesting fact about narrow-spectrum drugs. It was nice talking to you, and since Gil isn't here, I'm just going to log off for now. So, all right, everyone, take care.
All right. Okay, where am I here? All right. Okay, narrow spectrum drugs. Well, I did have a special guest that was supposed to pop on, but I guess he won't make it. So let's just jump straight into the drugs, shall we? All right, so the very first narrow spectrum drug is phenytoin, aka Dilantin. Now, phenytoin is a narrow spectrum drug in a class called anticonvulsants and is used for simple and complex partial seizures. It's commonly used in surgeries or post-surgery to stop active seizures. You may have had a patient who was actively seizing and the physician prescribed Dilantin via IV to stop it. That's very common. Mechanism of action. So phenytoin is another sodium channel blocker binding to those sodium channels, keeping them closed so the sodium can't get through and transfer the action potential. Now, as far as side effects are concerned, there are actually quite a few, and they vary from patient to patient, as they all do. But here are some common side effects you'll hear often. So you'll hear unsteadiness, cognitive problems. Dilantin has actually been linked to cerebral atrophy since the 1980s and is believed to play a part in issues such as thought processing and memory, body hair growth, skin problems. There are reports of red or purple blisters on the skin. These typically go away on their own, and the affected skin usually dies and peels off. Still not a great thing to experience, I'm sure. And lastly, osteoporosis. There's reliable data that repeated administration of phenytoin may cause osteopenia, which may be due to bone loss by inhibiting bone formation, thus leading to osteoporosis. So at therapeutic levels, there is no significant change on the EEG. It's possible you may have mild slowing. However, in general, you won't see an effect. However, in toxic levels, though, phenytoin can create generalized slowing, affecting every channel on the EEG as you see here. So moving on to phenobarbital, or as I've always heard it been referred to, phenobarb. Phenobarbital is a narrow spectrum ASM used in simple partial seizures. It's hard to say. Now known as focal aware, complex partial, now known as focal impaired, and generalized tonic-clonic seizures. It's also regarded as the go-to medication for seizures in infants and is also used to treat status. Phenobarb does work well with others, so is commonly used as an add-on medication to assist other ASMs in the therapeutic process. The mechanism of action for phenobarb is another GABA receptor enhancer. Now remember, that opens up the receptors letting chloride in, and chloride and electrical impulses don't jive, in turn stopping the impulses from spreading to the other neuron. Now, I know I might sound like a broken record, but I think it's helpful just to repeat this over and over so you'll know it. I dream of this stuff because just repeating it. And I would love for you to have that as well. So side effects of phenobarb include depression, hyperactivity, and impaired attention, especially in children. Memory issues, speech impairment, rash, addiction, and birth defects are all part of phenobarb's side effects. So at non-toxic doses, you see, interestingly enough, an appearance of beta in the anterior region that transitions to the posterior region. And in toxic doses, however, you have a generalized beta appearance that may progress to burst suppression if administration is even higher. All right, so here we are at carbamazepine. Carbamazepine is actually the very first ASM that I remember learning as a young tech that targeted a certain seizure type. I remember Dr. White at Denver Health, shout out Dr. White, giving us a little tip to remember. Tegretol, which is the brand name for carbamazepine, the TE in Tegretol should help you remember the TE in temporal lobe epilepsy. So I don't know why it stuck, but that's how, along with focal aware, focal impaired, that's how I remember that Tegretol is the go-to for temporal epilepsies. So Tegretol is a sodium channel blocker. We've touched on that enough. All right, so all of these listed here are side effects of Tegretol. Again, everyone feel free to pause the video if I've been going too fast on these, and write these down. It's a really good way for you to remember and digest the input. So I want to make sure I keep on time and get through all of these medications. So of all these side effects, there is strong data that says around 36% will experience dizziness and drowsiness, and about 32% will experience nausea. The rest of the reactions are under 10%. All right, so I'm sorry to say that this is the last time I'll be using myself as a crutch. I do think this is decently explained, if I do say so myself. I worked really hard on this, so I'd love to share it with you. Also, I can't find the sample that I used in this video, so that's another reason I'm using it. So enjoy this really quick clip.
Now let's take a look at the EEG changes. According to a 2020 article published in the Epilepsy and Behavior Journal, 616 EEG tracings were analyzed to determine CBZ's effects. In contrast to the patients who did not receive CBZ, those who did are associated with slower posterior alpha frequency, along with pathological, generalized, isolated spike in waves.
All right, so moving on to pregabalin, also known as, and what I consider the best brand name on the market, Lyrica, like a song, like it's lyrics to a triumphant path to a seizure-free life. That's pretty optimistic, isn't it? So Lyrica is used for focal aware and focal impaired seizures. Pregabalin reduces neurotransmitters that transfer action potentials. And obviously, when that happens, seizures are reduced. There are some side effects when taking pregabalin, and they're mostly functional impairment, such as vision changes, whether it be blurred or double vision. Coordination issues listed are clumsiness and unsteadiness, which actually may go hand in hand. Dizziness, drowsiness, and impaired thinking are also side effects. So this is interesting. Right here on the left in A, you have a normal EEG 2 weeks before onset of pregabalin treatment. B, you have EEG 2 days after the onset of the psychotic episode. You have generalized slowing, epileptiform discharges in both posterior head regions, maximal on the right. On the C slice, you have the EEG after the intravenous administration of 4 milligrams of lorazepam, restored background activity with intermittent slowing in the right posterior head region. And then lastly, you have the EEG 2 weeks after onset of the psychotic episode with resolution of the clinical symptoms and then a return of the normal background activity. So this is a really great illustration of the stages of effects that pregabalin has on the EEG. So familiarize yourself with that. And I believe if you type in pregabalin effects on the EEG, this might be the first image that comes up. So take a look at that. All right, so we're finally here at lacosamide. And you know what that means. This is the very last one. We're almost there, y'all. So let's get through this. Let's finish strong. Lacosamide, you may have heard of this one. Vimpat is the brand name. It's treating focal aware, impaired, and secondary generalization are the treated seizure types. Sodium channel blocker, as a lot of them are. There is some data out there that shows it may also react with collapsin, if I'm saying it right, collapsin response mediator proteins, in particular protein 2, by a process called phosphorylation, which is a huge can of worms that we won't get into right now. Just know that it's a sodium channel blocker for sure, but also might interact with specific proteins, and that will be sufficient enough for you to understand the MOA. So what are the side effects? She's not having a good time. Lacosamide seems to have all the usual suspects, as amazingly demonstrated by our actress model. We have some nausea, we have vomiting, diarrhea, dizziness, headache, drowsiness, unsteadiness, and tremors. So the whole gamut. All right, so what are the effects on the EEG? So although rare, lacosamide may decrease the alpha frequency in the posterior region, slowing it down to the into a theta range, as we see here. Now, when looking at this, it may appear that the patient is transitioning into drowsiness. So be aware that it could be drowsiness or it could be the medication effect. All right, that's it, everyone. Hey, thank you for spending time, spending an hour with me. If you want to learn more, you can check out my YouTube channel. Just type in my name, Gil Solano, in the YouTube search bar, and the channel Epilepsy Explained will pop up, and you can see these videos that I showed there. Also, I want to say thank you to Neuropathways for making this available for techs in our field. This is super valuable, and I'm honored to be a part of it. So thanks, everyone. Have a great day. I hope this was helpful. Again, rewind if you want, take notes, but thank you so much for spending this hour with me.
Hello everyone, Gil Solano here, and welcome to Season 2 of our Neurodiagnostics discussions, where today we will be going over a high-level overview of anti-epileptic drugs, also known as AEDs. We'll be going over each drug more specifically in upcoming videos, so make sure you subscribe to our YouTube channel or follow this profile so you don't miss out on those. By the end of World War II, anti-epileptic drug discovery was largely conducted by pharmaceutical companies, which was a bit out of the norm because in years prior, universities and clinical schools were the main contributors to drug studies. Anti-epileptic drugs. Anti-epileptic drugs are simply medicines that reduce the frequency of epileptic seizures. AEDs should not be considered as a cure for epilepsy, but instead as a treatment to suppress seizures while the drug is in the body. Now, AEDs can be categorized into two different groups, narrow spectrum and broad spectrum. Narrow spectrum AEDs mostly work for specific seizure types, such as partial, focal, absence, or myoclonic seizures. Broad spectrum AEDs have some effectiveness for a wide variety of seizures. Now, let's take a look at 15 common AEDs and what category they belong to. Feel free to pause the video here and copy this list on a flashcard. Again, we will be going over each drug more specifically in upcoming videos. There are various mechanisms of action in which AEDs suppress seizures. Mechanism of action. An AED's mechanism of action, also called the MOA, is how the body and the drug interact with each other in order to suppress seizures. Feel free to pause the video here as well so you can write down these common MOAs for AEDs. While you take in this list, I want to reiterate that an MOA is essentially what the AED does to the body to reduce seizures. And try not to be overwhelmed by this list because these MOAs will be included in individual breakdowns of each AED in upcoming videos. We've categorized these MOAs into blockers, inhibitors, enhancers, and other or unknown. And there you have it, folks. Don't forget to leave a like and share with a student or colleague. And don't forget to subscribe to our YouTube channel or follow my LinkedIn or Facebook profile so you don't miss out on the videos where we will break down each individual AED in further detail. Thanks, and I'll see you in the next video. A quick but detailed overview of the anti-seizure medication carbamazepine, starting now. This video is brought to you by Arium EEG. Hello everyone, Gil Solano here, and welcome back to yet another neurodiagnostics discussion video where today we will be going over the anti-seizure medication carbamazepine, also known as CBZ. CBZ was developed in 1953 by a Swiss pharmaceutical company and was perhaps the first anti-epileptic drug distributed on a massive scale. Initially investigated as a drug for depression and psychosis, its effects on seizures were discovered by animal screening, and in 1965, quickly gained a reputation across Europe as the most promising anti-epileptic. Brand names. Brand names for CBZ are Tegretol, Tegretol XR, Carbatrol, Epitol, and Equetro. CBZ can be taken by both adults and children who are at least 1 month old, and since it's a narrow spectrum AED, it is used to treat a specific seizure type such as partial seizures, secondary generalized seizures, and tonic-clonic seizures. It's important to note that CBZ is not effective against other generalized seizure types such as absence seizures or myoclonic seizures. MOA. CBZ's mechanism of action, or MOA, is a sodium channel blocker, meaning it binds to sodium channels and keeps it closed, stopping sodium from passing through. With sodium blocked from entering, the electrical signal is stopped. And with the electrical signals reduced, the brain is more stable and seizures are more controlled. Side effects. Common side effects of CBZ include skin rash, dizziness, drowsiness, nausea and vomiting, headaches, dry mouth, and weight gain. Side effects may happen in more than 1 in 100 people. They're usually mild and go away by themselves. Now let's take a look at the EEG changes. According to a 2020 article published in the Epilepsy and Behavior Journal, 616 EEG tracings were analyzed to determine CBZ's effects. In contrast to the patients who did not receive CBZ, those who did are associated with slower posterior alpha frequency, along with pathological, generalized, isolated spike in waves. And there you have it, folks. That concludes our very short discussion on CBZ. Don't forget to share with a student or colleague, and let us know in the comments below what you would like to see next. Thanks, and I'll see you in the next video. If you have epilepsy, there's a good chance that you're taking valproic acid, aka valproate, as it is the most widely prescribed anti-seizure medication worldwide. It's also helpful in managing migraines and bipolar disorders. More on that later. Valproic acid's unusual history begins way back in 1882 when it was serendipitously used as an organic solvent to help dissolve other anti-seizure drugs into liquid form. And it was only by pure accident in 1963 that the use as an anticonvulsant was discovered. Talk about luck. Valproate can be administered intravenously or by mouth, in syrup or tablet form, and is helpful in treating seizures such as absence, partial, and generalized seizures. That is a quiz hint. Common side effects include, but not limited to, dizziness, nausea, vomiting, sleepiness, and dry mouth. Serious side effects can include liver complications or failure, pancreatitis, and can increase suicidal risk. Now, this obviously isn't a medical advice channel, but typically it's strongly recommended to avoid valproate if you are living with any of these risk factors. Feel free to pause the video here so you can get a good grasp on this contraindications list. Brand names. Brand names for valproic acid are Depakine, Depakote, and Stavzer. Mechanism of action. The way a drug interacts with our body to stop seizures or regulate mood is called the mechanism of action, and valproic acid's mechanism of action is still unclear. However, most researchers agree that this is most likely a GABA enhancer. Let me explain. In our last video on Topamax, we went over how a neurotransmitter called GABA opens up receptors on the neuron and allows chloride to pass through those receptors. When chloride passes through those receptors, it stops the electrical activity. Well, unfortunately for GABA, there's an enzyme called GABAT. That's GABA with a T if you couldn't tell. And GABAT is kind of a bully to GABA. Now this is what GABA actually looks like. And GABA breaks down GABA every time it comes into contact with it. And with less GABA, the receptors stay closed and chloride isn't allowed to flow through. With chloride unable to flow through, that allows electrical activity to pass through. Okay, we're almost done. When valproate is taken, it binds to those little bully enzymes and blocks them from picking on GABA. That allows GABA to keep the receptors open and allows chloride to pass through more frequently, therefore reducing electrical signals. And that's how valproic acid helps reduce seizures and manage bipolar disorders.
All right, everyone, it's quiz time.
Now that we know valproate is used to treat absence, partial, and generalized seizures, what category of medications does that put it in? A, broad spectrum drugs, or B, narrow spectrum drugs? Answer in the comments below. Hey everyone, want to learn more? Check out this video on how valproate helps people with Lennox-Gastaut syndrome. So 2 things today. We're going to learn some really interesting facts about levetiracetam, aka Keppra, but also, did you win last week's contest? Stay tuned to the end of this video to find out. Today's video is brought to you by Arium EEG, a remote EEG monitoring company. Levetiracetam could possibly be the most go-to drug to treat epilepsy. Commonly referred to by its brand name Keppra, it's a relatively new drug first approved in the United States in 1999. It's crazy to think for comparison, if you remember in our last video about phenytoin, that was discovered in 1908. Keppra came along 91 years later.
I'm waiting!
Used alone or with other medicines, Keppra can help control seizures such as partial, myoclonic, or tonic-clonic seizures. It's still debatable on the proper age to take Keppra. However, the Food and Drug Administration has approved the use of Keppra for adults and children over the age of 4. Now, we talked about Keppra being the most common brand name, but levetiracetam's other brand names include Keppra XR and Epilepsy XR. Keppra can be taken via tablets, extended release tablets, and intravenously. Side effects. Side effects include dizziness, drowsiness, low energy, decreased appetite, headache, and weakness and irritability. Now let's get to the nerdy stuff. What you're seeing now is a typical unmedicated neuron, and that green ball moving down the neuron is a vesicle full of neurotransmitters. And the red thread-like protein surrounding it is called SV2. Now that vesicle needs SV2 to help it release the neurotransmitters once it gets to the end. After binding to the receptors are then opened up and the electrical signal is now able to pass through. All right, remember, that was a normal neuron vesicle without Keppra. Now let's take a look at that same vesicle in a patient who has taken Keppra. These are the molecules in Keppra binding to SV2 and stopping it from releasing those neurotransmitters from the vesicle. And now that there are no transmitters on the receptors, the electrical signal is stopped and therefore seizures reduced. Now this is about the time where we go over the EEG effects. However, most studies show that Keppra doesn't really affect the EEG in therapeutic doses. And that's it, folks. Thanks for watching. Hey, before you go, don't forget to subscribe to this channel and leave a comment. That's by far the best way you can help support our videos. And no, I didn't forget the contest winner. Congratulations to Sharon Lamb Davis for winning the Yeti mug. Someone from our staff will be messaging you shortly. Thanks, and I'll see you in the next video. We have a real doozy today, and you're gonna know a ton more about topiramate than you did just a few minutes ago. So let's jump into it. In 1979, a pharmacologist by the name of Bruce Marinoff, along with his team, discovered the compounds of topiramate while doing research work at McNeil Pharmaceuticals. But it wasn't until 1996 when topiramate actually became available for commercial use. Now, topiramate actually has 2 uses. The first being epilepsy, which we usually discuss on this channel, but it's also used for migraines.
I had a headache this big.
Now, in terms of seizures, topiramate is a broad spectrum anti-seizure medication, meaning it is helpful in treating patients with both partial and generalized seizures. Topiramate can only be taken by mouth and is approved for adults and children aged 2 years and over. Also, its half-life is relatively long, so most patients only have to take it once daily. Brand names for topiramate are Topamax, Qdexy XR, Topirigen, and Trokendi XR. Side effects. Now, I've got to be honest with you. There are so many side effects to this drug that I'm going to throw up a list here and you can pause it just to take it all in. Mechanism of action. Topiramate's mechanism of action has long been unclear. However, recent studies suggest that it reduces seizures in 2 ways. By first, blocking sodium channels, and secondly, enhancing GABA transmission. Now don't let me lose you just yet, because we're gonna go over each step one by one. What you're seeing now is a normal passing of an electrical signal in an unmedicated neuron. This is a sodium channel, and this is sodium. When sodium passes through the sodium channel, it allows the electrical signal to pass through as well. And just like in all sodium channel blockers, topiramate binds to and closes the sodium channels. This blocks the sodium from going through and therefore blocking the electrical signal. Deep breath, we're almost done. All right, now for the next step, there's 3 characteristics at play here: GABA, GABA receptors, and chloride. And this is GABA. GABA is a neurotransmitter in the brain that binds to the GABA receptor. And this is the GABA receptor. GABA receptors allow chloride to pass through the neuron. This is chloride, and chloride is simple. It simply stops electrical signals from passing through. All right, now, GABA will bind to the GABA receptor, periodically opening and closing it. And when it's open, chloride passes through and temporarily stops the electrical signal. When it's closed, electrical signals are able to pass through. Remember that topiramate binds to the sodium channels? Well, when it does, it also binds to the GABA receptors and keeps them open for a longer period of time. This allows chloride to pass through more frequently. And what happens when the chloride is passing through? That's right, the electrical signal is stopped. We did it. We're done. Hey, before you go, don't forget to subscribe and leave a comment down below. It's by far the best way you can help support our videos. Thanks, and I'll see you in the next video.